The history of direct care and treatment from the state hospitals to behavioral health system. This presentation will cover the history of direct care and treatment, starting with the institutional phase in the old state hospitals through deinstitutionalization and into the more recent history and the process of becoming a behavioral health system. In 1841, a Massachusetts woman named Dorothea Dix saw people with mental illness being abused and mistreated in jails and prisons. She started a movement to create asylums for people experiencing mental illness, places that could provide them with the care and treatment they needed. That started a trend across the country. States began to build asylums for people experiencing mental illness, and as the country grew, the number of asylums grew as well. When Minnesota became a state in 1858, the legislature immediately saw the need for such an institution. Initially, they entered into a contract with Iowa and sent people to the Iowa Hospital for the Insane in Mount Pleasant. But Iowa needed beds for their own residents and sent Minnesotans back in 1866. That same year, the Minnesota legislature authorized Minnesota's first asylum. The St. Peter Hospital for the Insane opened in a temporary building in 1866. By the end of 1872, 1,000 patients were in St. Peter. All but 6 had been ordered by a judge and escorted by a sheriff. And Minnesota didn't stop building for almost a century. 10 more state hospitals were built across the state. 1879, Faribault and Rochester. 1890, Fergus Falls. 1900, Anoka and Hastings. 1911, Gillette and St. Paul. 1912, Wilmer. 1925, Cambridge. 1938, Moose Lake, and 1958, Brainerd. The state hospitals were communities unto themselves. While some residents would get better and go back to the community, many lived most of their lives in these institutions. The campuses and facilities were massive. St. Peter had over 800 acres at the end of the 19th century and 60 buildings by 1972. Fergus Falls had over 2,000 beds. Many had farming operations: St. Peter, Faribault, Wilmer, Anoka, Fergus Falls, and Rochester. Farms provided both work and food for the patients, and also some food was sold for revenue to support the hospitals. Farming operations continued into the 1960s. There's a lot written about the history of St. Peter and a good document on Fergus Falls as well. There's a museum on the St. Peter campus in Old Center. Old Center is the only remaining building or part of the original Kirkbride building that was on the lower campus. That museum displays a history of the treatment of mental illness and is worth a visit. State hospitals had and still have cemeteries. Over 13,000 people were buried in these cemeteries, many in graves that had only numbers, not names. 8,000 now have names, thanks to an effort over the last 30 years. State hospitals served as a place for people who didn't fit in the community, were deemed inappropriate for the community. The first state oversight board for state hospitals was a board that was created in 1883 and had oversight of prisons as well as state hospitals. The common denominator there being that both of those institutions serve people who are not deemed appropriate for the community. Most of the people who were put in state hospitals were put there through courts, some kind of a commitment process, and brought there by law enforcement. The terminology that was used at the time, the names that were on the buildings, reflected a lack of understanding of mental illness and intellectual and developmental disabilities. What we now consider treatment was not available. The theories of treatment were separating people, getting them out in nature, allowing relaxation, getting away from the stress of life. Unfortunately, in addition to rest and farming and being out in nature, some patients were restrained, put in seclusion, and treated in ways that we no longer condone and often consider abuse. While they were called hospitals and treatment language was used, really they served more as giant specialized charities. Charities that were for the people who we didn't know what else to do with and didn't have a good way of serving, and served as sort of a ground for separating people from society who we didn't know what to do with. It's very important to understand that as the state hospital system was built, it was serving more than just people with mental illness, which is what we often think of when we think of the old state hospitals. Particularly important as we get into this 20th century is that state hospitals were caring for a lot of people with intellectual and developmental disabilities. Faribault, which was built in 1879, was specifically built as a school and hospital, quote unquote, for people with intellectual and developmental disabilities, many of whom were children. In Cambridge in 1925 and Brainerd in 1958 were also specialized in the IDD population. In this era, children born with disabilities, developmental disabilities, would be turned over to state guardianship when they were very young. This seems cruel, but at the time, families didn't have the resources, and there were no community resources to help support raising a child who had disabilities. As you can see here, as time went on, new facilities were built that were also focused on specialized populations across the state, including other people who were not really welcome or deemed appropriate to live in the community. Now we'll move into talking about the period of deinstitutionalization. Change began for the state hospitals in the middle of the 20th century, opening a period of decades of changing priorities and the focus of the system, and ultimately a downsizing and closing of the state hospitals. This photo is Minnesota Governor Luther Youngdahl on Halloween night in 1949. He's setting fire to straitjackets and other restraints that were used at the time at the Anoka Hospital. And you can see in the background there's a couple of nurses from Anoka looking on. Governor Youngdahl captured the spirit of the era. By this action, we have liberated the patients from the barbarous devices and approach which the devices have symbolized. By this action, we say to the patients that we will not rest until every possible thing is done to help the families, help them get well and return to their families. This spirit had really spread across the nation and sparked the deinstitutionalization movement. Deinstitutionalization was a broad national movement. By the middle of the 20th century, it was really being driven a lot by advances in the treatment of mental illness, most notably advances in medication and the creation of drugs like Thorazine and other tranquilizers. What those medications allowed was so people to live in the community, even with serious mental illness, and be able to live appropriately with the help of and support of medication. But there were also a couple of other factors, and there was really a big part of it being a change in public attitudes across the country on how we should care for people with mental illness and people with developmental disabilities. This was driven in part by a rights movement growing out of the civil rights movement that focusing on the rights of people with disabilities and people experiencing mental illness. But also a big part of it was scandals within the state hospitals themselves, nationally and in Minnesota, overcrowding, abuse, mistreatment of patients. St. Peter in the 50s had 3,100 patients, which is triple the population it held in the 19th century. This was the beginning of the end for the state hospitals in Minnesota and across the country, but they did not go quickly and they did not go quietly. Deinstitutionalization in Minnesota took slightly different paths for people experiencing mental illness and people with intellectual and developmental disabilities. For people experiencing mental illness, the medications that were introduced in the 1950s made even people with a serious psychosis or diseases like schizophrenia able to live in the community with the support of medication. That often meant that their stay in a state hospital might be only 3 to 6 months instead of several years. And that allowed them to go back to the community. As a result, there was a large drop in the number of people with mental illness being served in state hospitals, from over 11,000 in the late 1950s to 2,400 in 1972, an 80% reduction. For people with intellectual and developmental disabilities, changing norms mattered a lot. Fewer children were being committed to the commissioner and put into state hospitals, and community support started to be developed so that to support families as they were raising their children in the community. For the state hospitals, also very importantly, there was a lawsuit in 1972 called the Welsh lawsuit, which resulted in the Welsh decree in 1980, which was sort of a settlement between the state and the plaintiffs that required that all people, all individuals, intellectual and developmental disabilities, be moved out of state hospitals. And the reduction again was dramatic, from over 6,000 people in the mid-60s down to 2,650 in 1980 when the Walsh Decree took effect. By 2003, there were only 32. As these changes progressed through the 1960s and early 1970s, it was becoming clear that the state needed a plan for what to do with the state hospitals. In 1974, the Department of Public Welfare delivered a report to the legislature recommending that all the state hospitals be closed and that 5 be closed before 1980. This early momentum didn't lead to 5 being closed, but did lead to 3 closures during that time period. 1973, the Gillette Hospital in St. Paul was transferred to a hospital board and run privately as a nonprofit. 1978, Hastings facility was transferred to the vets and run as a vet's home. And in 1982, the Rochester State Hospital was closed for budget savings. This started a conversation that will be ongoing for the next 3 decades, beginning a very long process. This brings us into more recent history, completing the path from the state hospitals to behavioral health system. So the 1974 DPW report recommended closure of the state hospitals with declining census and more people living and more services in the community. But the downsizing and closure conversation quickly became a conversation about jobs. The communities that had hosted state hospitals for decades had benefited from hundreds of well-paid state jobs. St. Peter knew this right away and saw it in 1866. That's why they sought to be the first community to get a state hospital. They saw the infusion of state funds into the local community as a huge advantage for building a community there in St. Peter. This started a long and winding process of examination of the purpose of a system with all these large hospitals. With the advances in treatment and the shift to community living and services, these massive buildings and large campuses were quickly becoming obsolete. But the conversation about jobs and mission also kind of interacted. Desire to keep jobs could sometimes lead to efforts to find a purpose to justify the existence of the state hospital so as to retain the jobs. And of course, inevitably, these conversations were happening more and more in the political realm. Emerging from this conversation over time is a more focused question that is still our challenge today. What is the role for state-run services in Minnesota's continuum of health care? The primary evolution during this time period was the creation of regional treatment centers. Regional treatment centers, RTCs, were largely a sort of reconfiguration or rebranding of the state hospitals. The idea was to pull together a set of services in each region, so treat each state hospital as sort of a regional center for inpatient mental health treatment, residential treatment and care for people with intellectual and developmental disabilities, as well as substance use disorder. And this happened mostly in the 60s and 70s as, first of all, they started moving a lot of people with intellectual and developmental disabilities out into each state hospital. So places where they may have been overcrowded in one place were moved to another place. And usually in the region that individual with disabilities lived. So someone who might have been in St. Peter and was from the northwestern part of Minnesota moved to Fergus Falls. And the campuses all around 1969 or 70 started setting up their own substance use disorder programs, which had previously been mainly in Willmar. So that then resulted in this set of services in each region across the state were run by the state, kind of filling gaps within the continuum of care within those areas. State hospitals were formally renamed regional treatment centers in 1985, but as I said, that process started earlier. And by the mid-1990s, the system as a whole became known as state-operated services. In the 1980s and 1990s, there was a large policy shift within human services, essentially a shift toward delivering services in the community, particularly for those with developmental disabilities and people experiencing mental illness. This was supported by community standards and values. People wanted to live in the community, families wanted people to live in the community, and aided by a change in federal Medicaid law, we call medical assistance here in Minnesota, that helped develop a new system of supports for seniors, people with disabilities, and the same thing for people experiencing mental illness, although it was a little patchy and more sporadic than it was for people with disabilities. These funding mechanisms essentially gave state-operated services the idea of follow the money, as it were, to look at how they could develop services in the community where people wanted them, but still have it be services with state employees and state run. The first step in this was in 1988, the state-operated services substance use disorder programs that we call CARE programs began to bill for reimbursement just like private providers in the community did through the state's Consolidated Chemical Dependency Treatment Fund. One of the first innovations in move toward community services was MSOCS, Minnesota State Operated Community Services. At the time, the state was really under pressure from the Welch lawsuit to move everyone with disabilities out of the state hospitals and also to develop a network of community services to help support those individuals in the community. MSOCS was part of this solution. The idea was to create state-run community service for people with disabilities in the same regions that the RTCs existed in, and essentially repurpose the state workers out of the state hospitals into delivering community services. Pilots were started in the 1980s, and in 2002, some regional efforts were pulled together into what we know as MSOCS today. Essentially, this was a way to leverage some of these funding streams that have been set up using the Medicaid or medical assistance funding for MSOCS to use state employees to deliver those services and to have services in the communities, group homes, day programs, and vocational services to serve people with intellectual and developmental disabilities. The downsizing continued through the 1990s as 2 more RTCs were closed with declines in census and the move to community services, 1993 Moose Lake and 1998 Faribault. Both were converted to prisons, which of course keeps the jobs in the community. The closure of state hospitals was itself a very big deal, particularly for the employees that were involved and for the work that was involved to ensure that all employees had rights to jobs within the state somewhere, otherwise to be paid off in some fashion with severance. It was always a very big operation to actually close one down, even if it was being transitioned to be another service within the community. So let's stop for a second and take a look at how this was actually impacting the census within state-operated services and within the state hospitals. Overall, over the period shown here, about a 15-year period, it's about a 2/3 drop in the number of people being served in the RTCs. Of course, there was a huge change that's highlighted here for developmental disabilities as all those people started to move to the community. But the pattern is kind of consistent across most of the services, continuing decline in adult mental health being served within state-operated services, big drop in nursing home census as state-operated service moved toward a more narrower definition of forensic patients, and a drop in the chemical dependency treatment services as well. So now let's move more fully into the 21st century and look at the next big reform in the story toward DCT. In the early 2000s, the legislature created a planning process. It was a regional planning process that was focused on bringing together people from the different regions of the state, including counties in a prominent role, to plan for the continuum of care for people experiencing mental illness in Minnesota. A big part of this was to look at the need for psychiatric hospital level of care if the state hospitals would close and what would be the need to fill that gap. Eventually, this process recommended the creation of 10 community behavioral health hospitals, small 16-bed hospitals that we put around in the areas more or less where the state hospitals, the regional treatment centers, had been providing this level of hospital care. Between 2006 and 2008, the 10 CBHHs did open. The 16-bed model, a smaller size hospital, was not accidental. That was done in order to access Medicaid reimbursement. When Congress created Medicaid in 1965, they essentially limited the ability to pay for hospitals that served only people with mental illness to much smaller facilities like these 16-bed facilities. So again, you see here, state-operated services looking for a way to operate in the community with community payment systems like Medicaid, rather than through a state appropriation like the state hospitals. Not all of the CBHHs have survived. 6 still operate today. 3 also operate now as step-down programs, intensive Residential Treatment Services, or IRT services, and one did ultimately close. And with the creation of the CBHHs, we reached the end of the state hospitals. The last of the three large RTCs were closed: 2005 Fergus Falls, in 2007 Willmar, and in 2008 Brainerd. At the time Fergus closed, it had 60 patients in a facility with 2,000 beds. The old Kirkbride building still stands in Fergus Falls. DHS, of course, still operates on three of the old campuses, St. Peter, Anoka, and Moose Lake. And Direct Care and Treatment also still owns the Cambridge and Brainerd campuses. So before we move into the last part of how we became Direct Care and Treatment, there's one more story to tell, and that's the story of the growth in the Minnesota Sex Offender Program. The state had had a civil commitment statute for psychopathic personality going back to 1939. 1980s and 1990s, county attorneys started to use that statute more and more as a way to civilly commit sex offenders. The legislature responded by creating a new program called the Sex Offender Program, which opened on the Moose Lake campus in 1995. It was quickly expanded to add 50 beds in 2000. The expansion and the growth in the program really came from a tragic incident. A young woman in Grand Forks, North Dakota in 2003 disappeared. She was found 5 months later dead near Crookston, Minnesota. The man arrested for the crime was a level 3 sex offender who had recently been released from a Minnesota correctional facility. The result was explosive. County attorneys, who are elected officials, began to seek commitments at a much higher rate. No one wanted to be the one to let the sex offender out. At the same time, at the state level, the state became more restrictive and aggressive in how they made recommendations for civil commitments for offenders that are being released from prison, and on the DHS side began to oppose all discharge petitions. Essentially, the front door was wide open and the back door was closed. You can see down below on this slide the commitments, the difference in commitments, a 6-fold increase before and after the murder of the young woman in North Dakota. And here we can bring up to date our look at the census in the program and see, of course, the dramatic increase in the psychopathic personality sex offender group, how that represents close to half the people you see in Direct Care and Treatment today. You also note the continuing reductions across pretty much every other category: substance use disorder, adult mental health, nursing homes, and then the addition of community-based services at the bottom of the slide, which brings the total up slightly higher than there was in census in 2003, but a lot of that is really due to the increase in the sex offender program over that time period. A series of crises hit state-operated services in the early 2010s. There were two significant lawsuits: Karstens, which was a lawsuit that challenged the constitutionality of the Minnesota Sex Offender Program, and the Jensen lawsuit, which started as a suit against use of restraints in the METO program at Cambridge, but eventually spread system-wide and became a system of use of restraints and oversight on the use of restraints. In addition to managing these two lawsuits, each of which had court jurisdiction for over a decade, underfunding and understaffing and the changes in restraint policies really impacted facilities and created a very dangerous environment. St. Peter's Security Hospital, there was a terrible patient abuse issue that led to a conditional license on the facility. In addition to that, there were a couple of other assaults, including a terrible assault on one of the staff individuals there and patient-on-patient assaults. At the same time, Anoka was dealing with a change in the commitment statute that required most people from jails to come to Anoka very quickly. And so the population being served in Anoka changed almost overnight into being a population almost entirely from jails around the state. This resulted in more aggressive patients and, again, danger and assaults, resulted in CMS threatening to pull funding and certification at Anoka. This resulted in a lot of problems, but essentially a lot of employee fear for their own safety, for the safety of patients, for our ability to provide proper care to the people that were in our care. The problems and the crises that happened in the 2010s were in part because the organizational and governance structure of state-operated services not really kept up with or fit what the system itself had become. Up until the late 1990s, state hospitals, or the RTCs, had really operated almost independently as entities out in the local field, and not with very limited coordination or leadership coming from the state. In the late 90s, that started to change, and there was more taking of central services and centralizing those at the state level, as well as more leadership coming from the state. And as time went on between the late 90s and up until the early 2010s, that evolved to be a higher level of leadership within the State Department as well. But it was still this very regionalized structure. It was still a lot of lack of really centralized control and oversight of what was going on within the system, and a lot of local responsibility. When Marshall Smith was appointed in 2016 to a new CEO position for state-operated services, he started to direct a change and move us toward a behavioral health system. That's also the time at which the name direct care and treatment became the norm for how we talked about these services. So direct care and treatment was reorganized into a health system focusing on serving people that other providers cannot or will not serve. They created an executive team led by the CEO and composed of the executive directors of each of the service lines and the system-wide leaders. The regional leaders that existed in the old state-operated services structure were taken out, and it was made into more of a formal direct line structure of reporting. They also more fully centralized all the central services, and really a large focus on quality and pharmacy and compliance. And that helped to really address and be able to manage some of these issues as they were happening in a way that wasn't really possible when the old structure was in place and those instances first came up. And this takes us to the end of the presentation and the history of direct care and treatment and how we came from the old state hospitals into the system that we have today.